to our D series. My name is Christine Minoto. I'm the director of UCSF Roseman Institute. I would like to introduce you to our speaker today, Ian Duncan. So many of you probably have attended his talk previously. Ian has a lot of experience in understanding about the value, the actuary, how do you measure your economic value. So one of the things I talked to Ian to have him back is talking about how do you know what's the value that you need to ask for the payer to pay for? Because I think everybody is working hard to create a technology or a solution, but again, like what's the right way to measure your value? How do you structure your contract? What component is important in terms of negotiating with the provider or with the payer? So with that, today's talk, Ian's going to cover a lot of that. And so a little bit background of Ian. Ian is also a professor at our sister University of California, Santa Barbara. And he's also the president of Santa Barbara Actuaries, company that provide healthcare predicting modeling and actual services. So his background, before he became the adjunct professor, he had a graduate degree in economics from Balliol College in Oxford and his PhD from Heriot-Watt University in Edinburgh. He's also a fellow of the Social Society of Actuaries, and he also a book writer. He's an author for a book. His latest book is the second edition of Healthcare Risk Adjustment and Predictive Modeling. So Ian has wealth of knowledge that I'm so pleased that he was very kind to share that with you. And so without further ado, Ian will share with you his insight, but I want to let you know that he will take questions along the way. So if you have any question, post your question on the Q&A section on the bottom of your Zoom, and then Ian will go on certain times to check your Q&A section. With that, thanks.
Thank you, Christine. It's a pleasure to be back here. It's been some months since we last did this presentation, so this is a follow-up to the one that I did before. Let me just display this. And you're right, I'm very happy to say that I got some pro bono legal advice from one of your collaborators. So that was very useful as we proceed with our own startup in my company. So the topic today is value-based contracting, part 2. And specifically, I'm not going to address all the things that Christine mentioned a moment ago. We'll have to do another presentation on that, I think, at some point. Today, I was going to focus on the issue of gains and losses for the outcomes of any kind of value-based contract. Any kind of value-based contract where you're taking risk, you are at risk of either showing a gain or a loss in your program or your device, whatever. And there are certain techniques that you may want to think about in terms of how you price, how you incorporate the risk of gains and losses into your pricing and negotiating with a payer. So I'll move on here. This is today's topic. Last time when we did the presentation, I began by saying that you're an entrepreneur, you've developed a great new device, founded a startup, obtained FDA certification. Have you thought about how to get paid for your device, your startup, whatever? And today we add on the additional bullet here that if you enter into a risk contract, how do you ensure that you actually get paid for the value that you create and that you avoid the potential for gains and, or rather you capture the gains and avoid the losses. So we'll talk a little bit first about what value-based contracting is, just a recap of the first part of the series, and then talk about assessing, pricing, and managing contract risk. Christine went over this, so I'll flip over it. Just in case you're interested in further reading, There's a link here to the first part of the discussion, the making the case for your value proposition to payers that I talked about last time. That presentation is still available. You can download it here. And the other thing that I've put into the slide is a new book on health insurance, for which I wrote a chapter called Value-Based Contracting in Healthcare. And you can do a free download if you're interested. There's a link here to this particular chapter. It's very much the same material that I covered in the presentation last time, but may be interesting to some of you to actually have a printed chapter to refer to from time to time. So that's some additional follow-up material if you're interested. So brief recap for part one. The market evolution is very strongly towards value-based contracting. Back in the 20 years ago, we did pay for quality, we did pay for performance, but we've moved into contracts that incorporate shared savings. There are bundled payment contracts, all the way up to the most risky contracts of all, the full risk, sometimes capitation, but certainly full risk contracts. And CMS, as you know, is promoting this kind of value-based contracting very heavily. The theory is that from the HC plan group down in North Carolina or Tennessee, I forget which, at Duke, is promoting the idea that something between 50% and 100% of US health dollars will move through some form of shared accountability or downside risk contracts over the next 5 years. So that takes us to 2027. And in some parts of healthcare, we may see as much as 100% of contracts with some form of shared accountability and particularly downside risk. And the downside risk element is what I'm going to talk about a bit later in this talk, how to avoid downside risk when you're actually doing a good job and saving money for the payer. So once again, financial value proposition for a payer is what you need to have in order to enter a contract. You need to have a financial value proposition. You must be willing to take risk. You need the contract form for a value-based contract. And more important, I think, once you enter into a contract, you need to organize yourself or your program in order to perform against the contract. You need to do this from day one, and you need to do it regularly and purposefully in order to make sure that you achieve the kinds of gains that you expect to deliver for the payer. I introduced a couple of important definitions last time that were probably new to some of the more clinical folks who watched the presentation. Per member per month cost, when you're dealing with a payer, is the basis on which you'll be judged very likely. Per member per month cost consists of total medical costs plus admin costs divided by total enrolled member months. And that's the way that healthcare payers, employers, and insurers think about the cost of services that they deliver. And your objective is to reduce this cost per member per month. Another way to look at this is in terms of the medical loss ratio. So more contracts are now being written in terms of medical loss ratio, because this is very interesting, particularly in the Medicare Advantage space, which is total medical costs divided by total premium revenue. And so we are beginning to see more contracts in which a provider or a startup is agreeing to take risk around a projected medical loss ratio. The idea being that they will knock 2, 3, whatever points off this projected medical loss ratio. I went through the 5 components that we view as being important in successful contracting. The first of these is understanding whether there's an opportunity. I gave some examples last time where there either is or is not an opportunity to save enough money for a payer, you certainly need to deliver potential savings. My rule of thumb is you need to have a potential ROI of at least 1.5, maybe 2 times the cost of any kind of program. You need to be able to save net of the cost that you're charging for the program, at least $1 PMPM over the entire population. So the opportunity, assessing the opportunity before you enter into the contract is really critically important. Also, to continue to assess opportunity as, if you're dealing with a payer, as new groups are brought into the value-based contracting that you're going to be managing, because each one of these requires what's effectively an underwriting. Does the new population, if it's an employer, for example, does the new population offer the same opportunity to save money that you've seen on other populations? So opportunity is the beginning. Understanding the economics of the program is critically important. You need to know how and where you create value. How do you bend that trajectory that the population is on? The population is on some sort of upward trajectory. If you're going to save money in your program, you need to bend that downwards and generate savings. The third of these, and this is something I'm going to talk more about today, is the idea of assessing the risk around that assessment. So in step 2, you've perhaps estimated how much you can save, but that's a mean. There's a lot of variation around that mean as a result of the stochastic variability in claims. And so you need to understand how much you are at potential risk, even if you appear to be doing a good job, because the claims may vary against you. You could end up having to pay money back even when you have saved money. It's somewhat difficult to comprehend, and I'll give some examples in a moment. You need the contract terms, and these contracts are complicated, and they do need to be carefully thought out in terms of the terms that you include in the contract. And then finally, particularly if it's a shared savings type of arrangement, you need to be able to do outcomes evaluation and measurement of return on investment for the payer. So those are the 5 components. I went over those last time. There's just a very quick scan here of different components that go into the calculations. Don't worry about the individual terms here. The purpose of this is to show that these are complicated contracts with a number of different moving parts and a number of different variables that you need to consider as you put together your contract. I'm going to skip over this and get to what new material I was going to talk about today, which is the idea of assessing, pricing, and managing the risk on the contract. So you want to, if you've entered into one of these contracts and you're managing a population in some way, you want to be sure that you are actually paid for the value that you create. And ensuring payment requires management of 2 risks. The first of these, obviously, is operational. Can you successfully manage patient financial outcomes? Can you actually do what we talked about a moment ago in terms of the economics of bending that cost downwards? Can you successfully manage the patient population to generate savings? But the second part, which is really what I want to talk about in a moment, is the statistical variation. Can we evaluate financial outcomes? When we evaluate the financial outcomes, will the results accurately reflect our value? And this is known in actuarial space as model risk. So here's an illustration of what I'm talking about here with this concept of model risk or statistical risk. Here we have a shared savings arrangement with an evaluation design that compares the cost of the enrolled or attributed patients with the cost of members who are not in the program. So we often get into designs where you're comparing a population of patients that have enrolled in your program with patients who are similarly situated but who did not enter the program. And there's various statistical techniques that we can apply to ensure comparability between these two populations. And the typical evaluation design says, I have population A and the comparison population B. I'll look at the end of the year, once I've done all my matching and I've added up all the costs of these two different populations, and look to see what the difference is. And the important point here is that you have, for example, a total population of 2,500 people, 500 in this example, 500 enrolled in your program. Without any adjustments and assuming that people randomly join the program. So here we're saying there's basically no program. All I'm doing is taking 2,500 people, assigning 500 to a quasi enrollment group and 2,000 to a quasi control group. And I run multiple iterations to see what their costs are. What does that distribution of difference look like? And what we are saying here is the confidence interval or the variation around that mean. By the way, the mean is 0 because the population is randomly selected from a 2,500 population. The 500 are randomly assigned to, quote, this quasi-intervention group. 2,000 are randomly assigned to the control. So on average, we should see no gains and losses because they're essentially the same people. But because of the statistical variation in claims, what we see is a confidence interval that ranges all the way from losing 200 at the 95% confidence interval, meaning that 5 out of 100 times you would have a result that lies outside of this range, losing 240, gaining 240. But this minus 240 to plus 240 is entirely a statistical concept because you really are not managing this population. So theoretically, they should have no variation at all. But just the way that the claims variation, the stochastic nature of claims works, when you actually do this comparison, 5 out of 100 times, you're going to find that you either make a lot of money, more than 240, or less than you lose a lot of money, more than 240. And if you're in a gain sharing contract, a risk contract in which there's gain sharing, you can expect, if you happen to be on the bad end of the distribution, you can expect that 5 times out of 100, you will find that your evaluation of the results will come out as being minus 240 or worse, and you'll have to pay back money. So this may be a difficult concept to get your mind around, but it is something that's really key in this kind of contract. So that was an example where we randomly selected people and assigned them to the intervention, quasi-intervention population and the control population. If you look a little bit differently and say, let's say that our program is enrolling members that are more risky than the average population. We're enrolling an above average risk population. So we're going to assign the riskier group here to the intervention cohort, and then we have a control group that consists of the remaining population. Now we would expect that, again, because we're not doing anything with these people, that that we are not going to make a gain or a loss on the population, but because we were enrolling more risky people, we are finding that the whole distribution has shifted, and the lower bound of the distribution is now minus 745. So in 5 cases out of 100, you can expect to lose or appear to lose more than $745 per member per month. Now, in a risk-sharing contract where there's a downside risk, this would represent money that you have to pay back to the payer. And yet what this is simply a theoretical population here, where there is neither a gain nor loss. And yet, because of the nature of the people that you're enrolling here, you're at considerable risk of the volatility in claims resulting in this apparent loss on the contract. So even without selection, the evaluation appears to show losses. So what do these numbers mean? What they mean is that enrollment of high-risk patients results in significant losses when compared with the random population. You're at considerable risk of running an outcomes evaluation in which, simply because of the volatility of claims, it would appear that you have actually lost money for the payer, when in reality, operationally, you've done a good job and you've actually saved money. So in other words, in the 90% case, so 10 times out of 100, there's a probability that your measured losses will lie between minus 681 and minus 207. So you're going to appear to lose money 10 out of 100 times when you manage a population with these high-risk members. So even if your care management population is generating significant savings, a study may not report positive savings outcomes. And this is what we refer to as model risk. And the numbers probably are not all that realistic, because this is a synthetic example. But the point of this is to say, if you are going to enter into a risk contract with a downside risk where you might have to pay back some apparent losses, you absolutely need to understand what the variability looks like in the population that you're managing. And in a situation like this, you may want to go back and say, because we have a risk, say that the outcome is going to be between, let's take 75% as our example. So 1 in 4 cases, we're going to appear to lose somewhere between $500 and $250. You may want to increase the price that you're charging for your program to take account of the fact that there's at least a 1 in 4 chance that you're going to end up showing losses and having to pay some money back. That's a very, very important concept when you're negotiating these contracts. Very often we see, in fact, too often, we don't really see our clients negotiate around their expected savings. They expect to save $200 PMPM, and they're going to charge whatever their price is, assuming that they're going to end up at 200 PMPM. But if we go back to this example, and there's a risk that they could actually not save 200 PMPM, but lose somewhere between 500 and 250. That difference between the 200 and, let's say, the 250, we take the upper bound, the difference between minus 250 and plus 200 represents a potential loss to the company that, with a probability of 1/4, you may want to build some of that into the price that you charge to the payer in order to anticipate the fact that you run the risk of having to pay money back. This is a topic that we've written on, and there's an article that's available if you're interested. There's a link there. We looked at this risk in a specific situation, the Medicare Shared Savings Program. The Medicare Shared Savings Program, depending on the particular version that you're in, you can gain. If you save money, you share with Medicare 50% of the gains above a corridor, but you're also at risk on the downside of having to pay back 50% of the gains, of the losses rather, to Medicare if you lose money. And we looked at this and modeled what the stochastic variability in the claims meant for the possibility that a company is going to have to pay back money even when they are generating savings. So there's an article, should you be interested in pursuing this further. Just as a reminder, the Medicare Shared Savings Program is a fairly typical design for a shared savings program, with and without downside risk, depending on which version. There's an illustration here as to how it's constructed. Medicare will make, or CMS will make a projection based on your population as to where they think costs would be next year. And if you come in under that projection, you run the possibility, if it's a gain, you can share 50% of that difference, the sort of brown area there. You can share 50% of that difference with CMS. They'll actually pay you some money back. Or if you lose money, you end up having to pay CMS 50% of that difference. So that's the basic concept here, and it's a basic concept of a shared savings model. By the way, we're talking here about shared savings models specifically because this is a Medicare program, but this would work equally with any other kind of risk where you're doing outcomes evaluation. And so, for example, if you were doing a medical loss ratio projection, you project the medical loss ratio, but you're equally at risk that you're going to overshoot or undershoot that medical loss ratio simply because of the stochastic nature of claims. And you might want to consider, if you're in that kind of contract, you may want to consider how you build that risk into your pricing. The variation in claims opens the ACO to significant statistical or model risk, in addition to performance risk. But the model risk can be assessed. So you can, if you've got the claims data, you can assess how that variation is going to perform in a typical situation. And you can mitigate some of this risk through contract features. So when you're contracting, it's not just a matter of how do you price this risk into the price that you charge the client, but also what features or variables you want to build into the contract. And you remember I showed this slide earlier with key parameters for value-based contracts. A lot of these different variables here are dials that you can tweak in different ways to reduce the ultimate variability in those outcomes or the risk that you undertake. And a good example of this is the corridor that I mentioned earlier. You could have in fact, I think I have, yes, here we are. In the Medicare Shared Savings Program, there is a corridor. So there's an expected result, an expected cost of your population. You remember that's what you're going to be measured against. And what Medicare says is, for a particular size of accountable care organization or ACO, for a particular ACO, we'll set a corridor at plus or minus 3% of that expected cost. So there's an upper bound of 8,240, a lower bound of 7,760. And what Medicare says is if the costs come in anywhere between 7,760 and 8,240, there's no gain, no loss. So you could come in, for example, you're expecting the costs to be 8,000. It would be very nice if you came in at 7,500 because that means that you've actually saved $500 per member per year. And you can expect then to get 50% of that difference, $500. So CMS would send you a check for $250. That's great. If your number comes in between 7,760, in the 7,500 case, it's very clear, you get the gain. If your number were to come in, for example, at 7,800, now we're within the corridor. And what CMS says is we're within the corridor, no gain, no loss. So even though you've actually saved me, or you appear to have saved me $200 PMPY, we're not going to share any of that with you because we consider it to be within this variation that we're anticipating here. So the corridor is very protective if on the upside, you came in at $8,200. Now you've lost $200, and you could expect to pay back half of that $200 to CMS. But CMS again considers it to be no gain, no loss. So that the corridor is protecting you when you're not saving money. But on the other hand, you lose out because it does not reward you when you actually save money above the lower bound of the corridor. So a corridor is an important tool for managing your risk, particularly in smaller populations. One of the biggest challenges that we have is that populations are becoming smaller and smaller, and the volatility, obviously, because of the law of large numbers, the volatility increases as the number of members in the population decreases. So the corridor can be a very useful tool for reducing that outcomes evaluation or stochastic risk. The problem that you have with it is if you do a good job and you land within the corridor, you're not going to get rewarded for saving the payer money. So that's something to keep in mind as you really do want to model this. And that's what we did in our study. We looked at the distribution of savings outcomes, assuming no program. So what we did in the beginning of that previous example, we are just going to look at how the claims turn out, assuming no program, meaning assuming we're not saving any money. We are simply comparing two populations without any intervention. Corridors are an important risk mitigation technique in the Medicare Shared Savings Program, or in any program for that matter. Within a percentage of the expected outcome, any savings or losses are disregarded as statistical variation. Only savings or losses outside of the corridor are considered in the gain or loss sharing. And we modeled outcomes in our paper, assuming different corridors. We show that without introducing the interventions, there's a non-trivial probability, simply because of the variability in claims. There's a non-trivial probability that an outcome will fall outside the corridor. In other words, a provider could share in gains or losses even when none is generated by the program. And here are some of the results of our modeling that we show in the paper. The first of these is a total population of 3,000 members with a 5% corridor. You can see the 5% corridor is the two red lines on either side of the mean. So here we're looking not at the total cost, but we're looking at the difference in the total cost. As I said in the previous example a while ago, because it's comparing two populations with no gain, no loss, or no intervention rather, we expect the number, the mean, to be 0. But because of the randomness of claims, we see that normal distribution within plus or minus about 500, which is the corridor, you see there would be no gain or loss. But what's interesting here and what's important is what's your probability of lying outside of the corridor? In the upper end of the distribution, if your number comes in above 500, you have to pay back 50% of that money to CMS. If you come in below the 500, minus 500, so you've saved $500, you can share some of that. What's your probability of a gain or loss outside of the corridor? And the answer for the 3,000 member population with the 5% corridor is your probability of a loss is about 5%. And your probability of gain is about half of that. It's about 2.7%. So what does this mean in terms of how you contract? My opinion is what you should be thinking about is if there's a 5% chance that we're going to have to give back some amount of money in excess of 50% of $500, then that needs to be taken into account in our pricing. So you'd recognize how many members, you're going to lose $500 per member. You're going to share half of that. The math is quite simple. And you have a 5% probability of having to pay that money back. it becomes quite straightforward to figure out how much you should be considering in terms of an addition to your pricing to take care of the fact that you could lose money outside of the corridor. The second example is a 5,000 member diabetes example. Here we have a 3% corridor. So the corridor can vary, and as I said earlier, with smaller and smaller populations, the corridor needs to be wider. So we've got a bigger population here, 5,000 members who have diabetes. So they're higher cost members. There's 5,000 of them, and there's only a 3% corridor. Once again, you have a non-trivial probability that at least in 3.5% of the cases, you're going to end up having to pay some money back. And here the amount of money, because it's a higher risk population, diabetes, the corridor ends at around about, I don't know, maybe around about $800. So you potentially could end up paying back something in excess of $800 per member, or 50% of that in the MSSP program, paying back 50% of $800 per member in about 3.5% with a probability of about 3.5%. So again, this is something to consider when you are pricing your product and negotiating with the payer. So I'm just looking at the questions here. There's a question about devices and surgical tools versus therapeutics versus disposable supplies. I'm trying to think if we've got clients that we've done this kind of modeling for with devices. I don't see that it would be necessarily particularly different. The question is, what are you contracting? What exactly are you contracting for? Are you contracting for a reduction in cost in a population? And I think that once you figure out what the population cost is on a PMPM basis, you can figure out what the variation is in that expected outcome, and then price that into your price. There's a question that asks, what happens to the models if the shared gain loss relative to the corridor bound rather than the mean expected result? That I'm not sure I know how to answer that right now. I'm happy to follow up on that one, because I've not done any modeling that I can think of looking at the bounds. But again, I'm not sure how you would contract for that. Would you be contracting? Would you be contracting around, say, the upper bound instead of the mean? So I think if you're doing that, then you just come up with a probability of exceeding that upper bound. And I think you must end up in about the same place, don't you? One question here about how do you come up with a probability on the result being outside the corridor? This is a bootstrapping exercise, bootstrapping multiple. So there's 10,000 iterations pulling from the same claims distribution. So we're looking at what is the distribution of these outcomes. So we're comparing two populations. We bootstrap or randomly extract from the populations the means, take the difference between the means, and then say, what's the distribution of that difference? And that's what gives us these more or less normal distributions that you see here. But as you can see, what's important, and this is my point, is it's not all narrowly concentrated or narrowly distributed around the mean. There is this dispersion that occurs. And even though it may seem a relatively small number, 3.5%, given the size of the amount of money that you have to pay back, my point is that you can't ignore this. This is not trivial when you're pricing when you're pricing a program or a device or some kind of intervention, the probability that you could end up on the wrong end of the distribution simply because of stochastic variability is something you have to take into account in the negotiation. There's a question about, it's interesting that we have a question from New Zealand. So, gosh, what time is it in New Zealand? That's interesting. I think this is a question that deserves a longer answer than we have time for here, particularly because it's about mental health, which is a very interesting, we're seeing a very big interest in mental health. I'm happy to engage in a, let's see who asked that question. Adam, happy to engage in a conversation purely about this because it's mental health is a big interest of ours. We have a lot of clients that are trying to manage mental health, some with app-based interventions, some with human interventions, and it's an interesting area. I'm happy to have a conversation outside of this talk. Would this shared model work in employer-sponsored health plan? Yes, if the employer is contracting around an outcome like this, if the employer is contracting around a financial outcome, a gain in financial outcome, then yes, it'll work there. There are a couple of caveats. One of them is employer plans are by nature smaller than insurance plans. Therefore, you have this problem of the smaller n, greater variability that you need to take into account. The corridor becomes, I think, more important in that case. The second issue with employer plans that is really hard to deal with is that employers have so many different programs applying to the same population. And how do you contract in a reasonable way that it's your intervention or your program that's doing the heavy lifting for the employer, that's generating the savings? That's not necessarily a topic that we can address with this kind of modeling, but it is an incredibly important topic to take into account for contracting purposes. How does this apply to a drug? I think this applies enormously importantly to a drug. The drug manufacturers are more and more interested in real world outcomes. And this is what we're talking about here effectively is real world outcomes. I've had discussions with manufacturers about outcomes-based outcomes-based contracts. But I haven't seen, and you, Peter, may know more about this than I do, but I haven't seen good examples of outcomes-based contracts with drug manufacturers. But if you were ever to come up with one, then I think you would, this would absolutely be part of the discussion, because you've got all of those variables going on in a normal program, and you've got the drug variations as well going on. So I think that you're at great risk if you're entering into any kind of value-based contracting with a payer, if you're a manufacturer, that you would want to take into account the variability when you price your product. How would you consider geographic differences, West Coast versus East Coast or international? I haven't applied this internationally, though that's an interesting, that is an interesting idea. Well, let me just make a note here. I've certainly talked to the National Health Service in England about this kind of model, not necessarily the pricing here. It was much more basic discussions with the NHS. But the NHS's problem has always been financial, that they would like to introduce more provider-based risk arrangements like this, and provider-based risk arrangements, but they don't have the capital because they do require some capital to get started. And so they're sort of in a hiatus. I'm going to be in London next week, and so I'll find out a bit more whether there's, I mean, they've been completely blown off course by COVID, of course. So there's probably nothing much going on. Geographic differences, Christine, you want to make a comment about geographic differences?
Sorry, what was the question again?
The question I thought that you wanted to make a comment about was about geographic differences in this program between West Coast and East Coast providers.
In terms of how we provide program for a company who are in the West Coast and
I'm responding to a...
Yeah, I saw that question. I guess
you wanted to answer this question, I thought.
Would you consider your differences as West Coast? I don't know. I'm not quite sure with the question, actually.
Yeah, I mean, it's a good question in that there is such a lot of difference, but it depends who you're contracting with. If you're a provider, then you've got some location and you know what your providers can do. If you're looking at a payer group, I guess you have to just make sure that you want to make sure that your intervention population and your control group, if you're doing that kind of comparison, your intervention program and your control group are matched in as many variables as you can match them on, and that would include geography. But I don't see that the geographic differences would make a real problem unless what would make a problem would be if one group, for example, was heavier on capitation than the control group, and then you've got a real problem that you need to figure out, because you're not comparing apples to apples, and that's going to destroy the comparability. But that has nothing to do with this kind of model risk. That's just a basic problem with the comparison that you'd want to fix that. So those, I think, are all the questions. Yeah, I think that's all the questions. Let's go on. I think we're just about done. So what's the bottom line here? The bottom line is that statistical risk is real, and it's independent of your operational performance. Something that you need to take into account when you're contracting with the payer, that there's going to be variability in your outcomes, and you need to price that into the price of your program or device or whatever you're selling. Techniques exist to mitigate the risk. They have advantages and disadvantages. We showed the example of the corridor to show that there's an advantage because it mitigates your risk on the downside. But the price that you pay is that you lose some of the potential upside. The same is true of truncation. Truncation is another one of these mitigating factors that you will always want to truncate outliers because they can skew your results. But again, that you lose some potential savings if you're working on very high-risk patients. The attribution rules, who gets attributed to your population, and the pass-through rules, because sometimes there are certain costs that you want to pass back to the payer and not assume risk for. So the attribution and pass-through rules, these are other means in that very busy chart with all the different variables that you want to consider. And if you have the opportunity to do so, you want to include them in modeling and get a sense ahead of time what the risk is and what the different variables contribute to mitigating or increasing that risk, and how much then you want to add to the bottom line price in order to price in the risk in your contract. So in conclusion, I'll just say very good luck with your program, your startup, whatever it is, and good luck with reimbursement in dealing with payers, and more important, in managing the risk.
Well, that's great. Well, thank you, Ian. Is there any other question that folks want to ask? Otherwise, we can conclude. I think that's good.
There's one
one more question. Yeah.
One more question from Todd Roberts. If you have a good contract for a payer, how do you approach them as a medical device manufacturer to begin negotiation? I think that one's a really tough one. Actually, I'm just going to type something here. I think it's a really tough one because I think it's much tougher to approach a payer with a device than it is to approach them with a program. And in fact, a device without a program attached to it in some way is much more difficult, in my opinion, my experience, more difficult to sell to payers. I think you have to go through providers in order to convince the providers that there is a return on investment for them acquiring your device, and use them then to go to the payers. I can't think off the top of my head of an example where there are some examples. I had a client that had developed a new test for COPD, I think, or CHF, I forget now, it's been a couple of years. And they approached Medicare Advantage plans. And the idea was to get the Medicare Advantage plan to essentially pay for the device and then distribute it to the physicians that were in their network. So it can be done. But it's a really difficult proposition because you've got to show the ROI to the insurance company, and the insurance company then has to invest in your device, which means that they've got to invest up front, which is a little bit more difficult, I think. But it can be done. But my advice is, I think, to try going through the provider groups rather than directly to the payer. Adam, I put a email address in the chat. I hope you saw it.
Okay.
So those are the questions, Christine. Thanks for the opportunity. It's always good to talk to entrepreneurs.
Yeah, well, thank you for your time, and hopefully that was helpful. That was helpful for everybody who's here your talk, and hope to have you back again.
Thanks very much, everybody.
Thank you. Thanks, everybody.
Bye, Christine.